Okay. So I did introduce Nina. Oh, Nina's first.
No, I'm first. But...
Oh. Okay. Here are our beautiful keynote speakers for today. So Miho Kim is the executive director of the Data Center, which is an organization based in Oakland that does capacity building with communities, community-based organizations, and other institutions and agencies around a concept that I believe they coined called research justice, which is very powerful, and I think it's another way to think about community-based participatory research as making sure that the knowledge in communities becomes accessible to all, and that knowledge in communities is used to inform policies and programs and advocate for the rights of community members. And they do really amazing work in Oakland, and I encourage you to visit their website because they have lots of really useful tools on their website as well. And Nina Wallerstein, I'm sure many of you know her. She is based in University of New Mexico. She's the leader of the Center for Participatory Research there, and has been working in community-based participatory research for many years. And she's also a mentee of Paulo Freire and has written about popular education extensively. We're very fortunate in our department that she's done several popular education workshops. And she's currently engaged in a project. She does also a lot of work with tribal communities and is currently engaged in a nationwide project looking at community-based participatory projects across the nation and developing metrics and for evaluating those partnerships, and also looking at the added value of participatory research to outcomes. So a lot of her work is intervention research and looking at how CBPR helps to advance health equity and reduce disparities in health.
So it's a real pleasure to join forces with Miho today and trying to connect from both of our areas of expertise. And so I hope that this will be a time to, because today is focused on looking at how you start the design, not the partnering per se, but how do you work together to develop the health idea, to develop the design, to develop the project. And tomorrow, of course, will be on data collection and analysis. So we're trying to track through the research process with you. Some of you mentioned that you were less familiar with CBPR, so I'm going to actually give a little bit of overview of CBPR for those who need some or want more core definitions, and then to move forward together into a couple of my own examples of work. So first, I always start with who I am. I think our team has been writing a paper on researcher identity and what it means to work in communities. For me, as a white outsider in communities of color, what does it work to me in terms of my own privilege and status and power, and how do we cross and become good allies? So my own social location, my family was Jewish immigrants. I was raised in a very much Midwestern town, Topeka, Kansas, ethical culture, though there were no bagels or nothing in Topeka, Kansas, so it's no Jewish identity external, it was all in the family. But then grew up in the anti-war farm workers, spent a lot of time working in the farm workers movement, women's movement in my own college years. And Paulo Freire was a distant mentor, and then I actually got to work with him. And that was a terrific opportunity, Brazilian liberatory educator. I transferred, got myself into the academy somehow. I used to teach English as a second language, got myself into the academy, and then really tried to integrate Freririan philosophy, theory, methodology into an empowerment intervention focus, and became a researcher. I don't even kind of know how it happened, but it took me quite a while to get to my doctorate. But then started working with youth, alcohol prevention, healthy native. In the last 20, 25 years, I've had the great gift of being able to work within tribal communities in New Mexico and have indigenous partners and kind of learn from that experience, but also maintain my connections to Hispanic, Latino communities, and in Latin America, working with the Pan American Health Organization. So I've been able to kind of cross many communities. So I consider myself thinking in a lot of trying to learn and always be conscious of what does it mean to work within an indigenous context, being an outsider, and respecting that, yet at the same time theorizing how learnings from work with tribal communities can really inform work across all communities. So I just to theorize CBPR nationwide, so I'll be talking a little bit about that. I have a couple starting points I always come back to. It's like core. We talked about core values yesterday. But for me, the basic core is that research should not hurt people. And this is from Cheryl Crazy Bull, who's president of Northwest Indian College in Washington State. And that seems so simple, but it's a core value. And how do we assure we have integrity to not hurt, but rather to benefit? And of course, I go back to Paulo Freire. He wasn't a researcher, he was an educator, but to be a good researcher means to have faith. And I think, again, having faith in the people and our partners that we work with is the only way to change and channel opportunities to reduce disparities, improve equity, and change power relations. So again, it's a matter of faith and belief, and as someone so beautifully expressed, love and compassion yesterday. But I think if you look to the science of it, we need CBPR. Because there's such a challenge in intervention work of too much is focused on just learning if something works within a particular setting, if it's efficacious in one setting against usual care. But the idea that something can have evidence in a tribal community, even a Pueblo community, and still work in a Navajo community is a question. This idea of, in science terms, of external validity, the importance of translating what works somewhere. We're looking for what works. We're always looking for what works. But translating it, adapting it, and recentering it in a different community, in an urban community from a rural community, that's the key to external validity, and that's why we need community input all the way across. Today or yesterday, the release of the Institute of Medicine report, Sergio Aguilera just sent it to me from UC Davis, a colleague from UC Davis, that is a report on this infrastructure in medical schools, these clinical translational science centers. UCSF is one, Stanford has one, Davis has one, that really is demanding community engagement from these places of high elite academic knowledge. So we have a push from the Institute of Knowledge now that community engagement matters. So that's in the role of the importance of understanding context. There's a big question, and today I think we have an opportunity again to hear from different kinds of evidence all through this week. We tend to think of evidence-based practice, you pull it off the shelf, it works somewhere, and it's written, and it's published, and da-da-da-da-da. That's the only gold standard. There is so much evidence that's in community culture, that's in practice, what people are practicing that's not been systematically evaluated, that's in what people are calling community-defined evidence, that I think we have to begin to create what in post-colonial language you call a hybrid knowledge. Knowledge that brings together the academy and brings together the community and says this is all equal, and we have to find our way together. Because we have this challenge of one way, the universities used to mandate and used to sending information down to communities. That's not community partnership. And so how do we translate what we know, another challenge of course, into action? If we don't involve people, there will be no action. So from the science perspective, to really move towards getting the evidence out, having the evidence from the community go into the university, and moving from one context to another, to another, to another, and actually changing inequities, we need CBPR, and I'm glad the Institute of Medicine is now supporting it. I'm going to give you kind of an overview of where CBPR came from, a little bit of principles, a little bit of definitions, and then come to some examples. So we know that there's been historic abuse in communities. This is the long-time syphilis experience with the African American community. President Clinton did apologize in 1997, but research mistrust in Black communities actually goes back to knowing about the syphilis, Tuskegee syphilis experiment. There's a long history of use of debasing, awful language this is from a medical journal in the 1870s around Indians, the Apaches being unclean and debased and rude and drunk and worthless. How do you do research with people in a partnership if you have this perspective? So historically, this abuse of people, this stereotyping has been very real. In the Latino community, placebos being given to people without knowing, experimental measles vaccine being given to African American Latino babies in the 90s. This is not so long ago. This is not the 1870s. This is the 1990s. And of course, the current Havasupai. Do people know about this? How many people have heard about the Havasupai? Okay. Havasupai is a tribe in Arizona who had been working for a decade and more with a researcher around diabetes research, had given their blood samples, which is a very big thing to do, to give blood samples for research, and they found out through a very not direct way, a student attended a presentation and found out that these blood samples had been used, of course, research on schizophrenia, research on migration patterns, research on other mental health issues, not diabetes at all. And they were, of course, furious, upset, concerned about the sacred fluids being taken for a different purpose. They sued the university for violation. This is this decade. They lost the lawsuit, or they didn't quite go to lawsuit. They lost because the actual consent form was a little bit more ambiguous than could have opened it up. But the university realized that if they did not settle with the tribe, they would no longer be able to work with any of the tribes in Arizona. So Arizona State University settled and provided millions of dollars back to the tribe, and also sought their blood samples that had been sent around the country. I've heard people from Havasupai talk about this, and it's just a week that's so devastating. In my work, not with the Havasupai, this reverberated throughout every single community I work. It's been, so this current abuse still matters, and we have to think about it. It might not be so flagrant as this, but how do we protect our communities from the possibility of not working ethically and not working with their permission and authority to be working with them? So it's a very clear example to me of our need to be very watchful and careful about our work. And this is research which can be so beneficial is laden with these possibilities of powerlessness, where the university just does things, and distrust. So how can we recreate something that's different? So again, I guess one more slide of microaggressions. This is a term, I don't know if you know, but this is examples of microaggressions, kind of little remarks, little rudenesses, little ways that symbols violate a community's integrity. And this is just examples from Indian country, but there are examples, I'm sure, in other communities around microaggressions. So again, it's, racism comes in many forms. And so it's important to know that sometimes we have to just watch that we don't replicate certain of our own dimension, of our own challenges of living in structures that are unequal. So what is CBPR? Again, sort of a set of examples, or some definitions and principles. This is a commonly known definition from the W.K. Kellogg Foundation, which has a couple things in it. Collaborative approach that equitably involves all partners, recognizes unique strengths, so it comes from a strength perspective, not a kind of illness perspective, that also starts from a topic of importance to the community, rather than from our own topic. If I'm speaking, of course, as an academic from my own perspective as a university person. And the key to this is it's very applied. Its purpose is knowledge leading to action to reduce health disparities or improve health equity, if you want to call it that way. So a social change definition. The key thing here, again, on a definitional note, is it is not a set of methods. My students, I harp on this all the time with my students. It is not whether you do it qualitative or quantitative or GIS mapping or epidemiology or description or intervention. It's a general approach of how we work together. And so you can do any method. And the goal is, again, I'm talking about CBPR sometimes in a decolonizing way. How do we not replicate colonial relationships? By creating what in post-colonial language they call hybrid knowledge, where knowledge is truly valued from all sides. So yesterday, I think some of you really looked at a set of principles, that these are the common principles of CBPR from Barbara Israel et al., recognizing community as a unit of identity, cooperative learning, long-term commitment, how do you build that in, balancing research and action, that's what was in the definition. And then from a tribal perspective, again, I've learned a lot working with tribal sovereign nations, that if we're working with systems that have a government, then they have accountability to their community, and they can also say whether I can be there or not. So the shared agreements that we have, the tribal council resolutions that I have, the memorandums of agreement include data sharing, data ownership, and that they basically own the data as much as the university owns the data. University legal departments do not like that, let me tell you. But that's so how do you build in research data being owned? And we can only publish if the tribe approves. So even though you may work in other communities that don't have this defined leadership, the question is, can you bring the same set of principles? Where there's data sharing, data co-ownership, data that is only published with the authority of the community. So that's kind of some core bottom lines I've learned working with tribes. There's also a wonderful chapter on these other principles from an indigenous collaborative perspective. They're all R's, but they're nice R's: reflection, respect, relevance, resilience, reciprocity, responsibility, re-traditionalization, and revolution. So the kind of, how do you think of CBPR from this perspective? One last thing on definitions. Many of us think of community-based research that it should not be this way, but there's research that is done on communities. We target communities. We say, oh, we want to work with Hispanics in or Latinos in this neighborhood in San Francisco. We just go there. Others of us work in settings. We go to schools. We go to homeless shelters. We go to community centers. We go to churches. So we work within the setting. The question is, how do you move that into a with perspective? How do we still work within those settings in a school or a homeless shelter, but with partners, with the homeless shelter as a partner, with the people who are there as partners, with the teachers and counselors and principals as partners, not just in that setting. So think of your own partnerships. And are they moving towards, or can they move, or are they at the with perspective, or when you develop a partnership, think of it. Am I in the setting, or am I with the partner within that setting? It's kind of a nice, easy way to think about it. So I think what Catalina did yesterday was lovely in taking people through the whole research process. And my question always is, there are many steps in the research process, right? Identifying the problem, developing a literature review. Someone in our small group talked about that yesterday. What is, in my question always, the level of community voice in each of these research steps? That's the core question. And how much should the community do something? There's also different roles. People take different roles at different times. So I just put it in 3 different slides, the steps of the CBPR process. Yesterday we talked a lot about building partnerships, and I'm kind of reiterating today the importance of self-reflection, knowing our own core values, our own positionality. I said this was my position and social location, our own value-based. And there's a debate going on in the CBPR world right now about, are we just doing community engagement just to improve the research, just to improve screening rates, just to improve diabetes control, just to improve the specifics? Or are we doing CBPR, the added value of community engagement or community participation, for a much broader capacity building agenda? That's called the broad worldview, social justice worldview. So is it a utilitarian worldview, or is it a social justice worldview? I imagine in this room our people are trying to embrace or have the social justice worldview. But we also come from institutions with huge, in the case of universities, baggage. So I could be the best person I am, I hope I am a good person, walk into community, meet people, and at the same time there's been another history of another researcher in that community from my same institution, from the University of New Mexico, who's actually not been so participatory, and they have a skeptical view of the University of New Mexico because of that. So we come with the baggage of the institution as well, and that's important just to kind of recognize. But how do you create partners? How do you ensure participation all the way through? These are big questions in partnering. And we're going to do a little exercise at 11 today about choosing and thinking about partnerships. And the question is, you know, how to ensure who is participating. Sometimes it's just the providers. I know in NIH grants, National Institute of Mental Health, they're saying, well, where's the consumers in this participation, not just the providers? So, you know, who gets to participate with you is a big question. I wanted just to name this, that there is a kind of approach to knowledge creation called decolonizing or indigenizing or critical methodologies that really try and embrace this transformative idea that the research, again, is changed. And the research could be best grounded in community narratives, community strengths, community theorizing. I'm going to give an example of a community theory in a minute. And also practices that democratize knowledge. So what does it mean to involve the community in interpreting knowledge is where you really begin to democratize the knowledge. Not just in the data collection, because we have the next step after partnering, and this is where we are today, is how do we start negotiating health issues, the research questions, how do we assure that the community partners, community advisory board, we've actually made a shift in our language. Language matters. Freririan taught me this. We've always been called community advisory boards. I have a community advisory board. Our teams are now calling themselves tribal research teams. So they are co-researchers with us. So we now have TRTs instead of CABs, community advisory boards. We have tribal research teams that we're working with, and that's been a progress of 15 years of figuring that one out. You say, how come it took so long? But that's the goal, is to think about that. So the tribal research teams help us co-develop instruments, the sample, the interventions, and the evaluation. So that's kind of a question for all of us. The last stage we're going to talk about tomorrow is all this participatory data collection, analysis, interpretation. I'll just say one thing on this slide. The process most easily used by researchers is to involve community partners, community advisory board, tribal research team members, to help collect data, to train them as interviewers, all of that. It's harder to take people through the data analysis process and the core of data interpretation and bringing those results back to the community. If you don't do data interpretation together, you've lost a huge source of knowledge. You know, if you just take it home and do your SPSS or your qualitative analysis in your office and don't go back to do what's called member checking and qualitative research, but bringing it back to, you know, how is this knowledge useful to you? How are you going to use it to change practices, policies? So that's that role again, the critical role there of, say, data interpretation. So just to make two examples, we've been working for the last 15 years with a couple tribes in the development of approaches for families the last 5 years, and we actually have another grant working with the third tribe, to bring the family listing program as an intergenerational prevention intervention with seniors and kids and the parents to a life skills intervention. Working with two tribes, a Pueblo community, 3,700 people. They have a lot of self-governance. 80% of their population still speak their native language. They're the only place in the world that speaks this language. And then the Navajo community, 3,500, but it's really a lot of loss of language. The elderly still speak the language. And we had this, again, 12, 13-year partnership building on several grants. And they finally said to us, we were doing this assessment of their strengths and capacity, and their issues. And they said, we need help with our families because we're losing culture, we're losing language. Can you look for funding for us? So that was a really wonderful opportunity after we had done a lot of work together. And we found this Anishinaabe, this listening to one another curriculum by Whitbeck et al., working with the Anishinaabe people in the north, in the plains, and we said, well, you know, okay, this is an Indian curriculum, but it still is going to require a lot of steps to make it Pueblo and Navajo. So we took a full year working with our tribal research teams to actually re-change the whole curriculum and re-center it in their community. And we came up with a family listening project that was shared, Raymond Navajo, Hamish and Walatowa, that involved a lot of community visioning, community history, tribal history, and also had all these evidence-based family strengthening things in it. activities, exercises to strengthen communication. And we added a Freririan-based community action project so the families would give back to their communities. We took this to a third community, so we have 3 different versions of Apache Navajo Pueblo now, and we just submitted a large grant to test the effectiveness. And because we've been working for quite a long time here, the tribes have all agreed to share data. That's a very big change rather than just holding their data so that we can actually test the effectiveness with sufficient numbers. The problem with small communities is you don't have sufficient numbers for testing. So we're pretty thrilled about our potential here. I had a conversation around what does it mean to incorporate community knowledge. And one of our partners here in the room from the Santa Clara Urban Indian Health Clinic talked about bringing in historical trauma as an indigenous theory that has been really meaningful to communities around the trauma that's been induced intergenerationally from historic genocide and assimilation practices of the federal government. And there's actually been some now science brought to this by Corinna Walters of bringing historical trauma into a scientific inquiry. So this did not come from the science. This came from a community. Then the science has begun to look at it, and now it's getting known. So this is an example of where some of our best knowledge may come from the community. So lastly, I want to end with our national study that is trying to look at CBPR across the country. We have partners from the University of Washington, Bonnie Duran and her colleagues, and from the National Congress of American Indian Policy Research Center, Malia Villegas and her colleagues. And we're trying to look at, it's a 7-year window of funding. We're on our last year. We were able to survey 300 partnerships around the country and do 7 in-depth case studies and develop tools to evaluate partnerships. And this is our model. It's in your binder. You're going to work with it today. It's really quite simple. Does it look simple? Basically, it says that every research occurs in a context. I think Miho Kim's going to talk a lot about the context, whether it's a political context or an economic context or a funding trend context. And it occurs in the context of a collaboration between the institutions of trust and mistrust. If you understand that context, then the partnership dynamics will be influenced by that. Who's participating? What partners? What CBOs? What community-based organizations? What academic groups? What community-based organizations? What public health agencies? Who's participating? The key language here is if you have a partnership, it will change the next opal. It will change the way research is conducted, and it will change the way an intervention is created, which will incorporate community knowledge. It will change everything about the research. Then that change should influence a set of outcomes that include the grant outcomes, that include the intervention outcomes or policy outcomes, but also improves the idea of community capacity development. And what we did in our study is over a lot of input from experts around the country, community and academic experts, to create this model. We've done consultations with community partnerships around the country, whether it makes sense. Can they use it as a reflective tool? Can you use this model as an annual kind of opportunity in a partnership to say, where are we at with our trust? You know, where do we start? Where are we at now? Where do we want to be in 5 years? And how are we going to get there? Just as a reflection tool. In addition, we look for all kinds of instruments and measures of all those constructs in the model. We found them, we developed some new instruments, and those are on our website. They're on the websites here as well. But the Center for Participatory Research has all the instruments. You can download them. The National Congress of American Indians website has all the instruments. You can download them. And the same with the Indigenous Wellness Research Institute from Seattle. All the instruments. They're yours to use, adapt, change. But they're there. We're about to publish our psychometrics paper, which shows you that these skills hang together, that they're usable. I just want to walk you through three examples. one of the surveys instruments that we developed is for the principal investigator. It's really the facts, who's in the project, what's the funding stream, what are the dates, who decides hiring and decision making, what's the view of how partners are participating in the research. What kind of training is the partnership going through? Is the partnership committed to anti-racism? Is there an anti-racism training? That kind of questions. The next kind of survey was for all partners, both academic and community. We call this a community engagement survey. So these are the type of questions in that survey instrument. Context, capacity. A key thing that seems to be very, very important in our data that we're finding is that alignment with CBPR principles matters. So if the partners from the community are aligned in the core principles and core values with the academic partners, that improves outcomes. So we're finding the other thing that seems to matter is the type of governance. Who's making decisions matters in terms of outcomes. Trust matters in terms of outcomes. So we're just in the beginning. We're drowning in data in terms of trying to understand what matters. These are the 4 sets of outcomes we've identified in addition to health, but partnership synergy as a very proximal outcome. Cultural centeredness, how centered is the intervention, is the research in that context, in that culture. Then a scale that we got from UCLA, concrete and perceived outcomes, which is, did it change health status? Did it change community policy? Did it change health services? Did the research have an effect at that system level? Not just, and then finally, did the research impact people's personal development? Personal benefit, has there been a personal benefit to participating together? And those sets of outcomes. Just a reminder of what cultural centeredness is. This is a billboard that I was driving past up in the Navajo Nation, and I had to go a couple miles out of my way to come back and take a picture of it. But this to me is cultural centeredness. Have you noticed a change in your harmony, breath, energy? It may be TV. This would not be in New York City, right? So it's so important to understand from your heart and your soul what cultural centeredness is. And that's the kind of research we should be doing. So this is, to me, the example. We've been developing these trust indicators and trust typology. This is also in the websites you can get from a no trust place to a critical reflective trust. We always are going to make mistakes. We're always going to violate something with each other. We're people, So and partnerships go up and down. But if you have critical reflective trust, you basically have each other's back. And you're going to, how do you work through mistakes, or how do you work through challenges? And you can talk about issues of power. And that's a really important level of trust. A graduate student who's now just finished her doctorate actually has been tracking this trust development process from no trust, suspicious trust, through critical reflective trust, and finding a set of communication strategies that are very, very important for partnerships to work through. So we're going to be trying to, which include how much the whole partnership is oriented towards each other as partners, the level of respect, and the level of mutual participation. So these are building blocks to create more trust. This last slide here is, what are we evaluating when we're looking at CBPR? Certainly it's the grant. What are the goals of the grant, the outcomes of the grant, but it's even more broader than that, some intermediate outcomes of system changes, policies, practices. Then we can evaluate the partnership. How are we doing on trust? How are we doing on group dynamics? How are we doing on power sharing? How are we doing with each other? And that's where I would propose to you that this conceptual model may be a tool that's helpful to you, and the skills from our instruments and our qualitative instruments might be appropriate to you. But ultimately, we want to look at evaluating the bigger benefit to the community capacities, empowerment, skills, leadership, and of course, hopefully we're trying to impact health equity issues. I guess I did want to end with this one, returning to self-reflexivity. I've always loved this from Mary Northridge. She's the editor of the American Journal of Public Health, but she wrote a little editorial in 2003 about what CBPR is. She said, all you need to do is show up. You can't stay in your ivory tower. You got to show up in community. You got to listen and listen and listen and listen more. Be who you are. Don't try and be. I can't. If I tried to be native, that would be a disaster. I have to be who I am. the work, and then to believe in social justice. So I think it's really, these are core principles. And then to ask ourselves, what is the problem defined from each point of view, and what should be done about this problem? Many things might need to be done about this problem independently from research. There's a lot of spiritual practice in traditional Native communities that should never come under a research lens, ever. It should be private. And then what can we do together is the big question for me always. So I want to thank you and turn it over to my colleague, Miho Kim, to share her perspective.